Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 313 of our pharmacotherapy series, which majors in hypertensive crisis. The first question reads, M.O.M is a 60-year-old African-American man with a long history of heart failure with a preserved ejection fraction abbreviated as half-PEF, poorly controlled hypertension believed to be caused by non-adherence, and a history of myocardial infarction. He was referred from a community health center this morning for a thorough evaluation of his elevated BP. He has not taken his enalapril, carvedilol, or amlodipine for the past 7 days. M.O.M is completely asymptomatic. Physical examination reveals a BP of 180 systolic, 120 diastolic and a pulse of 92 beats per minute. Fundoscopic examination is pertinent for mild arteriolar narrowing, without hemorrhages or exudates. The discs are flat, his lungs are clear, and the cardiac examination is unremarkable. The electrocardiogram indicates normal sinus rhythm at a rate of 90 beats per minute. The chest radiograph is interpreted as mild cardiomegaly. Serum electrolytes, blood urea nitrogen, and serum creatinine are within normal limits. A urinalysis is significant for 2+ proteinuria. How quickly should his BP be lowered, and what therapeutic options are available? The absolute magnitude of BP elevation does not in itself constitute a medical emergency requiring an acute reduction in BP. There is no evidence of encephalopathy, cardiac decompensation, chest pain, or rapid change in renal function. Therefore, no evidence exists to indicate a rapid deterioration in the function of target organs. One would classify M.O.M.'s case as a hypertensive urgency. As is often the case, M.O.M.'s lack of BP control is related to medication non-adherence. M.O.M.'s clinical presentation requires that his BP be lowered during the next 12 to 24 to 48 hours while being careful not to induce hypotension. Rapid-acting oral agents can be used for this purpose. Parenteral therapy is not warranted. A number of different oral regimens using clonidine, captopril, labetalol, or minoxidil are available. Restarting his medications in a controlled manner so as not to drop his BP too rapidly may also be a reasonable option for treatment. Later, he can be converted to a regimen designed to enhance adherence by selecting medications with once-daily dosing. For example, lisinopril or another long-acting angiotensin-converting enzyme ACE inhibitor would be preferred for maintenance instead of the enalapril previously prescribed. One should also determine and address barriers to medication adherence with the patient, including cost of therapy, lack of understanding of the benefits of therapy, misconceptions of the side effect profiles, and so forth. Timely follow-up within 1 week after treatment of hypertensive urgency is of paramount importance for the appropriate management of these patients. The next question reads, M.O.M.'s physician has ordered immediate-release nifedipine to be given 10 mg sublingually. Is this appropriate therapy to treat his hypertensive urgency? Captopril, clonidine, labetalol, and minoxidil have all been used to lower BP acutely. These oral agents take several hours to adequately lower pressure and are therefore useful in treating hypertensive urgencies but not emergencies. Oral-acting ACE inhibitors, other than captopril, are not useful for acutely lowering BP because of a slower onset of action. The immediate-release calcium channel blockers, including diltiazem, verapamil, and nicardipine, can rapidly lower BP. However, the most extensive experience is with nifedipine. Nifedipine, when given orally or by the bite and swallow method, was previously recommended as a rapid-acting alternative to parenteral therapy in the acute management of hypertension. However, its use has been associated with life-threatening adverse events related to ischemia, myocardial infarction, and stroke. The cavalier use of immediate-release nifedipine to acutely lower BP is potentially dangerous and should be discouraged. M.O.M's BP can be managed safely using other oral medications. Captopril, clonidine, or labetalol can be used to lower his BP, and he can be restarted on his oral maintenance regimen with appropriate follow-up care. The next question reads, a decision is made not to use nifedipine, but rather to give M.O.M oral clonidine. What is an appropriate starting and maintenance dose? Clonidine is considered a safe, effective first-line therapy for hypertensive urgency. It is a centrally acting, alpha-2 adrenergic agonist that inhibits sympathetic outflow from the central nervous system. BP can be lowered gradually over the course of several hours using oral clonidine. Traditional dosing regimens have included an initial oral loading dose 0.1 to 0.2 mg, followed by repeated doses of 0.1 mg per hour until the desired response is achieved or until a cumulative dose of 0.8 mg is reached. Some authors, however, have cautioned against the use of sequential loading doses, citing lack of benefit over placebo and the potential for unpredictable adverse effects, particularly abrupt occurrences of hypotension. If loading doses are to be used, it is especially important to reduce doses in patients with volume depletion, those who have recently used other antihypertensive drugs, and the elderly. The acute response to oral clonidine loading is not predictive of the daily dose required to maintain BP control. Maintenance oral therapy with clonidine is somewhat empiric, however, total daily doses should be spread between 2 and 3 times daily dosing owing to the drug's short half-life. The next question reads, what are the adverse effects and precautions that should be considered before recommending the use of clonidine? Oral clonidine is generally well tolerated. Adverse effects include orthostatic hypotension, bradycardia, sedation, dry mouth, and dizziness. Clonidine can decrease cerebral blood flow by up to 28%. It should not be used in patients with severe cerebrovascular disease. Clonidine also should be avoided in patients with heart failure, bradycardia, sick sinus syndrome, or cardiac conduction defects, as well as in patients at risk of medication non-adherence because of the rebound hypertension. The next question reads, M.O.M has a history of half-PEF and normal renal function. Based on these findings, would captopril be a reasonable choice for initial treatment? How should it be given? What if his blood urea nitrogen or serum creatinine were elevated? Captopril has been used both orally and sublingually to acutely lower BP. Captopril decreases both afterload and preload, and lowers total peripheral vascular resistance. For this reason, captopril and other ACE inhibitors are often considered the drugs of choice in patients with HF with reduced ejection fraction, as they have been shown to reduce mortality in this patient population. M.O.M has half PEF. The evidence of using ACE inhibitors in improving cardiovascular outcomes in this patient population is not strong. However, given that M.O.M appeared to be well controlled on his enalapril therapy before abruptly stopping his medications, it is reasonable to restart a rapid ACE inhibitor and reinforce medication adherence issues. After oral administration, the onset of action of captopril occurs within minutes and peaks 30 to 90 minutes later. Clinically, it reduces BP within 10 to 15 minutes, with effects persisting for 2 to 6 hours. Sublingual captopril is as effective as nifedipine but without reflex tachycardia in acutely reducing mean arterial pressure in both urgent and emergent conditions. Despite these beneficial effects, captopril, as well as long-acting ACE inhibitors, must be used with caution in patients with renal insufficiency or volume depletion. In most cases, an elevated blood urea nitrogen or serum creatinine will provide a clue to the existence of these conditions. However, captopril can also induce renal failure in patients with bilateral renal artery stenosis or renal artery stenosis in a solitary kidney. Such conditions may not be easy to detect in the context of an acute hypertensive emergency. Therefore, in patients in whom these conditions can be excluded, captopril can be considered for therapy. First-dose hypotension is a common limiting factor with captopril use. This complication is most likely to occur in the elderly and in patients with high renin levels, such as those who are volume depleted or those receiving diuretics. Under these circumstances, initial doses should not exceed 12.5 mg, with repeat doses an hour or more later if necessary. Therefore, captopril would be a reasonable choice as initial therapy in M.O.M, which can later be replaced by a longer-acting ACE inhibitor. The next question reads, what other oral agents are used in the treatment of hypertensive urgency? Minoxidil, a potent oral vasodilator, has been used successfully in the treatment of hypertensive urgencies. An oral loading dose of 10 to 20 mg produces a maximal BP response in 2 to 4 hours and can be followed by a dose of 5 to 20 mg every 4 hours if necessary. Unfortunately, its onset of action is slower than that of clonidine or captopril. Another complicating factor is that beta blockers and loop diuretics generally must be used concomitantly to counteract minoxidil-induced reflex tachycardia and fluid retention. Because of this, minoxidil should only be prescribed by those who have experience with prescribing this agent and managing these adverse effects. These adverse effects make this agent a less than ideal choice in M.O.M because of his history of heart failure. Minoxidil should be used only in patients presenting with hypertensive urgency who are not responding to other antihypertensive therapies or who have previously been taking this agent. Oral labetalol, a combined alpha and beta receptor antagonist, is an alternative to oral clonidine or captopril for the treatment of severe hypertension, but the most appropriate dosing regimen remains to be determined. Initial doses of 100 to 300 mg may provide a sustained response for up to 4 hours. Labetalol 200 mg given at hourly intervals to a maximum dose of 1,200 mg was comparable to oral clonidine in reducing mean arterial pressure. An alternative regimen using 300 mg initially followed by 100 mg at 2-hour intervals to a maximum of 500 mg was also successful in acutely lowering BP. Other literature has reported that a single loading dose of 200 to 400 mg does not appear to be effective in achieving an adequate BP response. Because labetalol can cause profound orthostatic hypotension, patients should remain in the supine position and should be checked for orthostasis before ambulation. In addition, labetalol should be avoided in patients with asthma, bradycardia, or advanced heart block. The next question reads, M.S.R, a 55-year-old African-American man, presents to the emergency department with a 3-day history of progressively increasing shortness of breath. During the past 2 days, he experienced a severe headache unrelieved by ibuprofen, as well as substernal chest pain, anorexia, and nausea. His medical history includes asthma and chronic stable angina. His medications include albuterol via metered-dose inhaler, furosemide, isosorbide dinitrate, felodipine, and lisinopril. However, he discontinued these medications on his own 3 weeks ago. Physical examination reveals an anxious-appearing man who is alert, oriented, and in moderate respiratory distress. His vital signs include a heart rate of 125 beats per minute, respiratory rate of 36 breaths per minute, BP of 220, systolic 145 diastolic without orthostasis, and a normal body temperature. Fundoscopic examination shows arteriolar narrowing and arteriovenous nicking without hemorrhages, exudates, or papilledema. No jugular venous distension is observed, but bilateral carotid bruits are present. Chest examination reveals decreased breath sounds with bilateral rales extending to the tip of the scapula. M.S.R's heart is displaced 2 cm to the left of the midclavicular line with no thrills or heaves. The rhythm is regular with an S3 and an S4 gallop, no murmurs are noted. The remainder of M.S.R's examination is within normal limits. Significant laboratory values include the following: sodium of 142 milliequivalents per liter, potassium of 4.9 milliequivalents per liter, chloride of 101 milliequivalents per liter, bicarbonate of 23 milliequivalents per liter, blood urea nitrogen of 30 mg per deciliter, serum creatinine of 1.2 mg per deciliter, hematocrit of 38%, hemoglobin of 13 grams per deciliter, white blood cell count and differential within normal limits. Troponin is negative ×2. Urinalysis shows 1+ hemoglobin and 1+ protein. Microscopic examination of the urine reveals 5 to 10 red blood cells per high power field and no casts. Pulse oximetry reveals an oxygen saturation of 88%. An electrocardiogram demonstrates sinus tachycardia and left ventricular hypertrophy. The chest radiograph shows moderate cardiomegaly and bilateral fluffy infiltrates. What aspects of M.S.R's history and physical examination are characteristic of an emergent need to immediately lower his BP? Hypertensive crisis occurs most often in African American men and in individuals between the ages of 40 and 60. Furthermore, many patients who present with hypertensive crisis have a recent history of discontinuing the use of their antihypertensives, as is the case with M.S.R and M.O.M in the previous case. Recent onset severe headache, nausea, and vomiting are consistent with central nervous system signs of severe hypertension, as are the acute onset of angina, e.g., substernal pain, and acute heart failure, e.g., shortness of breath, increased pulse and respiratory rate, cardiomegaly, S3, and chest radiographic findings of pulmonary edema. The absence of signs of right-sided heart failure such as jugular venous distension or hepatomegaly suggests an acute onset of heart failure caused by hypertension as opposed to a gradual worsening of chronic heart failure. M.S.R's urinary sediment is relatively unimpressive at this time, especially in light of his history, and his ocular complications are minimal. M.S.R's presentation is considered hypertensive emergency because of the presence of heart failure symptoms. M.S.R should be admitted to the hospital as intravenous IV antihypertensive therapy is warranted. The next question reads, M.S.R is to be started on nitroprusside. Is this an appropriate choice of drug? What alternatives to nitroprusside are available? M.S.R's arterial pressure should be lowered with parenteral medications, which have a rapid onset of action. Nitroprusside, phenyldopam, and IV nitroglycerin all decrease total peripheral resistance rapidly with minimal effect on myocardial oxygen consumption and heart rate. Of these agents, either nitroprusside or phenyldopam would be preferred in patients with hypertension accompanied by decompensated heart failure in the absence of myocardial infarction. Parenteral nitroglycerin is similar to nitroprusside except that it has a relatively greater effect on the venous circulation and less effect on arterioles. It is most useful in patients presenting with angina secondary to coronary insufficiency, ischemic heart disease, myocardial infarction, or hypertension after coronary bypass surgery. In addition, nitroprusside and IV nitroglycerin may both decrease elevated left ventricular diastolic pressures in patients presenting with hypertensive emergency. Although nitroglycerin would be helpful for someone who is experiencing chest pain in the setting of an myocardial infarction, this patient is not having an acute coronary syndrome, which is confirmed by negative troponins and electrocardiogram. Before considering nitroprusside, it is important to consider the etiology of the chest pain. As described above, the chest pain is likely due to acute onset heart failure due to severe hypertension. Based on the signs and symptoms, it is not likely to have been caused by ischemic heart disease. In the setting of coronary ischemia, nitroglycerin has been shown to be more beneficial than nitroprusside. However, this patient does not have evidence of active coronary ischemia. Because the clinical presentation is more consistent with acute onset heart failure, it is important to focus on reducing peripheral resistance and decreasing elevated left ventricular diastolic pressures. Nitroprusside provides an advantage here because it provides both arterial and venous vasodilation, allowing for further reduction in peripheral resistance and left ventricular diastolic pressures. Nitroglycerin has a relatively greater effect on venous circulation, especially at lower doses. Thus, nitroprusside would be preferred in this patient. Phenyldopam and nitroprusside are equally efficacious in acutely lowering BP. Both medications have an immediate onset, are easily titratable, have a short duration of action, and are relatively well tolerated. Unlike nitroprusside, phenyldopam does not cause cyanide or thiocyanate toxicity. However, phenyldopam is associated with dose-related tachycardia and should be avoided in those with active coronary ischemia. Therefore, in the absence of any significant renal or liver disease, nitroprusside is the preferred treatment for M.S.R. Hemodynamic effects. Nitroprusside has many pharmacologic effects that should improve M.S.R's condition. It dilates both venous and arterial vessels, thereby increasing venous capacitance and decreasing the venous return or preload on the heart. A decrease in the pulmonary capillary wedge pressure and ventricular filling pressure will ultimately improve M.S.R's pulmonary edema. Afterload is also decreased as a result of arterial dilation. This action increases cardiac output, reduces arterial pressure, and increases tissue perfusion. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 314.